rename yourself, your first and last name, and the clinic that you're participating from. Please remember to mute your microphone when you're not speaking, and say your name when you unmute. If you can, turn your video on. It's great to see the community members, the new and the old faces. And if there's more than one of you, please do list the names in the chat for everyone who's joining from your group. There's CME credit for these echoes, and for all University of Washington faculty, staff, and students. You can complete the mobile text registration and sign in. And if you haven't registered yet, you can just send your email address to this 833-394-7078, and then you should receive a response that states that your number's been updated. And if you don't, then you can sign in through this other uwcme.org. And then after registration, and I think you have about an hour after the echo to text 10085 to the same number. And then you should receive the response stating that we've recorded your attendance for this University of Washington Project Echo Dementia. For all other people, we are tracking your attendance. It's recorded by Sammy. Thank you, Sammy. And through Zoom Analytics. So please make sure that you are displaying your full name, and Sammy can reach out to you if she needs additional information. There are so many other wonderful UW echoes. There's Echo Geriatrics, which meets on alternate Fridays, the third Friday of each month from 12 to 1:30. There's UW Traumatic Brain Injury Behavioral Health Echo that meets on the first and third Fridays of each month, same time. UW Psychiatry and Addiction Echo, and then telehealth, telebehavioral health training series as well. There's a really good consultation service for people who have high complex pain and high dose opioids, this 1-844-520 pain, and also the telepain series. Additionally, there are fantastic archives of grand rounds for neurology and psychiatry that are really great. And please consider, if you haven't already, signing up for the Dementia Innovation Summit, which is happening March 7th of next year, around the corner, really. And you can earn 6.25 CMEs, connect with like-minded professionals. It's going to be a day of a lot of discussion, a lot of skill building, and in particular around early diagnosis management and support of individuals living with dementia. So the Dementia Innovation Summit is focused and centers primary care at the forefront. Please do join. It's also open to specialty care, neurologists, other folks, anyone who's interested in really learning more about early diagnosis management and support of people who are living with cognitive challenges and dementia. And you see there's a QR code here. There's early bird registration until December 20th. It's been extended till December 20th. And you see the key topics here, which I'm not going to read, but dementia is absolutely a team sport. It's a group team effort. Many of the hub team members are speaking, so please consider coming down to Valley Medical for this conference in person. Okay. We know it takes time to prepare for cases, and we want to help you with this. And cases are so important. We learn from case presentations. And as we've said on a number of occasions, there's no case that is, too straightforward or too complex. We can all learn together. Please do bring your cases forward. And if you need help kind of putting them together, we can help support and guide that. And then on the right of this screen, what you see is that for each case that is brought forth to Project Echo Dementia, we, after we've had the case presentation, the hub team meets together and we discuss further all the comments and recommendations. And then Chris and I put together these recommendations, a case summary and recommendations, as you see here. So after review of the information provided, including sort of synthesizing all of that information, we reflect back what the questions were, what the kind of thinking of the community was around the presentation, and then how best to support this case going forward, how to really care for this person, given the number of issues that were raised during the presentation. And then we also put our information on this. We're available to speak further and take a deeper dive if that's helpful. So it's really a value add, we think and hope, for people who bring cases forward, that they get this summary and recommendations that comes from the collective of the community, and then is filtered through further discussion with the hub, and then written up and sent out. Okay. Reminder, of course, that we never reveal private health information or PHI. We want to protect that. It is not public, it's private. And all of the sessions are recorded and available on our website. And then please do complete the 1-minute survey, because it helps us to improve what we're doing together. We already talked about accreditation through University of Washington. Nobody today in the planning or in the presentation has any financial relationships to disclose. Here's our hub team. And we are comprised of people across Dementia Action Collaborative, University of Washington, Swedish Neuroscience, Overlake, Virginia Mason Franciscan. So we're really across many health systems. And here you see we've provided over 1,700 instructional hours since the inception in June 2020. And in 2023, 100% of respondents reported that Project Echo Dementia improved their quality of care for patients with dementia, and nearly 64% reported changes by others within their organization. So you see that there's this kind of local sharing of information, and that care is evolving as a result, kind of at the level of the health system that people are working in. So that's fabulous. 96 sites currently, over serving 250 zip codes and 243 providers. Please share. This is a way to sign up, either email directly Sammy or through this link that you see below. And we actually do have a case presentation. So without further ado, I would love to introduce Dr. Kristoffer Rhoads, who is professor of neuropsychology at the University of Washington, a co-lead of ECHO, and a dear colleague and a friend. And he's going to talk with us about financial capacity red flags, assessment, and interventions. Welcome, Chris. Thank you. Take it away.
Oh my goodness, thank you so much. And my apologies, I'm a little under the weather, so I'm going to try not to sneeze and cough my way through this, but absolute pleasure to be here. And thank you to Dr. Messier and Paige for being here also. It's the rare scenario where we get a case that dovetails with the didactic. And this is a really wonderful example of kind of the complexity of some of these issues. So let me go ahead and share my screen. I'm going to hope that's looking okay. And I wanted to update this. We did a capacity talk, or I did a capacity talk a couple of years ago, but we've got a bunch of new folks, which is lovely. And there's some things in terms of financial decision making that are relevant for today's case that I wanted to lean on a little bit more heavily. So I do not have any disclosures, although as I thought about it, I thought I should mention that I do have a very, very small private practice in forensic neuropsychology as part of my agreement with the University of Washington. And that does include capacity evaluations, although these are almost always retrospective capacity evaluations. So after someone is deceased and an estate comes to light, whether or not somebody had capacity to make changes to their will or other estate planning, which is about as narrow of a limb as I would ever go out on, depending on the case. All other clinical capacity evaluations I do here at Harvard University of Washington. So I just wanted to make a couple of distinctions, in terms of neuropsychology and within neurology and other healthcare settings. We really think about capacity more than competency. So competency is more of a criminal or like a civil term, whereas we think about certain capacities that drive our ability to do things like make financial decisions or medical decisions, and they really are decision specific. I think if you take anything away from this, it is, the evaluation depends on the decision that needs to be made. And really, that needs to be considered in the context of the laws, but it is not a legal determination. It may be evidence that a judge will then make a determination based on, but it's not something that we decide someone's competent. There are, psychologists and neuropsychologists and psychiatrists that do competency to stand trial or kind of other decisions, but that's not really what we're talking about here. And I also think of it, in the framework of you need to know the relevant law or legal standards by which capacity determination is made. But broader than that, you have to also think about the cognitive abilities that are the underpinnings to make those decisions. And those are different depending on whether it's a medical decision versus financial decision or testamentary or contractual, right? So here in the state of Washington, there's different levels of capacity within kind of each of these. We'll talk about that a little bit more. And then also thinking about, capacity in terms of the cognitive abilities that give rise to those decisions versus maybe the motor or physical limitations. So somebody with Parkinson's disease may lack capacity for financial decision making or financial capacity because of cognitive impairments. Alternatively, they may be perfectly fine from a cognitive standpoint, but have motor symptoms that interfere with the kind of more logistical or executional components of finances. And then also, thinking about thresholds at which these decisions are made. That here in the state of Washington, I would argue that there is a very low threshold for capacity, particularly presumed capacity, if a formal assessment has not been done. I think most providers are pretty familiar with the work of Applebaum and Risso. It dates back to 2007 now. The idea that somebody is communicating a consistent choice based on their appropriate level of understanding of both their situation and the relevant information around treatment choices, whether or not there are certain pros and cons. And certainly, simple decisions are one thing, more complex decisions with downstream outcomes. So that, that medical decision-making capacity about being able to consistently demonstrate and convey that choice, that is not the standard for which we think about financial capacity, testamentary capacity. And I have seen providers get in trouble, including some expert providers or expert witnesses who have applied this standard to financial or testamentary capacity decisions. Very, very different. We do know that older adults with mild cognitive impairment have a higher likelihood of having lack of capacity for medical decision making. So healthy older adults got about 2.8% that will have impaired decision making capacity. That number is up to 20%. Parkinson's disease up to 42%. Alzheimer's disease 54%, and then learning disability 68%, which is a surprising number. Go back and talk about that if that's of interest. But certainly, again, as the degree of cognitive change increases, medical decision making decreases. We also know that people with dementia, so dementia itself is not a decision point about capacity. So a number, a good proportion, 40%, will retain decisional capacity very early in the stage of the disease. And if you think about kind of cut points, if somebody has a mini mental of over 23, they likely retain capacity, not always, but likely, knowing that the mini mental does not do a great job assessing executive functioning, some other cognitive constructs that are critical for capacity. And if it's less than 19, more likely than not, going to lack capacity. We further know that without specialty training and protocols by which to measure capacity, physicians do a variable job of recognizing impaired medical decision-making capacity. So fewer than half were recognized, but when they were recognized, they usually corresponded with lack of capacity. And almost half of those who were inpatient lacked capacity, but only a quarter of those identified by the treating team. And this becomes super important in terms of acute conditions that would undermine capacity that are treatable, where capacity can be restored. So if we shift quickly, to the criteria for testamentary capacity, or the ability to, make and execute a will or a estate plan, the criteria here are different than those in medical decision making, but it's the understanding of kind of one's bounty, right? So what are my assets? Who benefits from my will? What is the distribution of those assets? And how do those all kind of integrate to form a plan? So those criteria, as you can see, go back to the late 1800s. And as one of the main challenges to testamentary capacity back in the 40s, the idea that if I have sufficient mind and memory to understand those things, and my estate kind of is pretty static and I know where it's going, that is kind of the criteria for testamentary capacity. Contrast that with financial capacity, which is more kind of loosely defined, although if you get into the psychological and neuropsychological literature, one of the agreed upon definitions is the ability to manage financial affairs in a manner that is consistent with my self-interest and my values, right? So including, where I might give money, how I might give money. Certainly, as cognitive impairment increases and isolation and other kind of things become factors, vulnerability increases also, and chronic conditions that are progressive raise risk for financial capacity being undermined at some point during that process, versus an acute condition where I might be temporarily incapacitated, but once that resolves, could be urinary tract infection, could be other organ failure, capacity can be restored. There are certainly gray areas of financial exploitation and undue influence, and these are rarely overt and coercive, but it's often this person with a close confidential relationship who is imposing their will over the will of the individual for their own gain. So just concepts there. When we do evaluations around financial capacity and risk for exploitation or vulnerability, there are a few forms that are in surveys that are helpful with that. So, asking about misuse of finances, that kind of cultivation of a close confidential relationship, and whether it's the title of a home or a vehicle, this idea of entitlement, feeling like they are owed, or you feel like you owe them money for all of the wonderful things they've done for you, which again, not a sign of exploitation, but certainly a red flag. Pressure, either overt or covert, asking for money, and then asking people about that kind of higher level instrumental activity of daily living around financial management. So forgetting to pay bills, paying them more than once. I usually ask about incidental ones, not just the things that are monthly, but things like the property taxes, the car registration. Those tend to be the first affected, and the monthly bills come next. When assessing financial capacity, in addition to neuropsychological evaluation, which is brief, I don't always do a comprehensive neuropsych eval during a capacity evaluation. Usually it's leaning heavily on the cognitive constructs that are critical to that capacity. Glenn Marson down at the University of Alabama has done excellent work with this, with kind of basic monetary skills, something as simple as, here's a dime, here's a nickel, how much are each worth, which one's worth more, all the way up to, tell me about your estate, your income, your monthly bills, some scenarios around financial judgment and risk, some checkbook management skills. So both the kind of basic concepts, instrumental functions, and then higher level financial knowledge. These, again, when I think about financial capacity, executive functioning and memory are two of the primary things that sleep about. There is also this model of thinking about someone's financial decision making, not just related to those things, but also this kind of psychological vulnerability of isolation or dependency on others to manage finances, or giving to the bank, susceptibility to undue influence. Again, that could be isolation, that could be reliance, dependency on others. The kind of core components that aren't too far off some of the other ideas of understanding one's financial scenario, making a choice, and then the consistency of that choice, both over time and with someone's values. So, absolutely nothing wrong with very generous donations to charities or organizations, but that changing inconsistent with values over time is a red flag and would be something to consider, think about financial decision-making capacity. And all of those things kind of work together to give you a sense of someone's financial decision-making ability and integrity of that. When we think about or look for undue influence, again, there's that close confidential relationship. So the red flags here, you can read all these things, but the red flags, the things that I keep an ear out for, are somebody who has become increasingly isolated over time and is now relying maybe on could be a family member, it could be a paid caregiver or neighbor or a new quote unquote friend who is now accompanying them to all of their medical visits, to the bank. They are their kind of primary social outlets. All of a sudden, maybe there's a change in banks, or there's a change in the long-term financial planner or the attorney. And then the poisoning of the well, where there's negative comments about other family members or the long-term financial planner or other care team. So again, these occur. They're not all indicative, but certainly red flags. And in terms of the actual evaluation, there are some kind of critical things here in terms of the timing is super important. So ideally, the evaluation is done in close proximity to whatever decision or issue that needs to occur is occurring. So the sooner the better in terms of the tightness of that timing. In my mind, I am also always front of mind is that you are thinking about taking away someone's rights. So that idea of balancing autonomy with safety, the idea of the least restrictive recommendations. And sometimes, I'm thinking about a case a little while ago where there was a question about someone's ability to create a will, somebody with early stage dementia. And the ultimate outcome of that was he had good knowledge of his estate, beneficiaries of his estate. His choices made sense in terms of things were equally distributed. So he had capacity to do that, but he lacked capacity to determine the executor of that. He could not identify somebody. So it was a nuanced, and the attorney wasn't super thrilled with that, but that was the reality, right? Had capacity for this one thing, but didn't have capacity for this other part. Unfortunately, it was relatively easy to appoint a neutral third party as the executor. Family wasn't psyched about that either. And of course, a prospective capacity evaluation is far better than a retrospective evaluation where you are reliant on the record, what was done at the time or around the time of the decision. And I guarantee you, having done a bunch of these, there's never enough information to make you feel 100% comfortable. So it's really challenging. And that is another encouragement. When you have concerns about capacity or family has concerns about capacity, documenting kind of your thoughts, what you've done, the things you have assessed, even if you're not comfortable making a full determination. So the general framework, again, knowledge of the legal standard, that has to happen first. That keeps you out of hot water in terms of applying the wrong standard when it comes time to either write your report or go to court. Knowing kind of the functional elements of what needs to be assessed, coming up with, if not, verifying or understanding the diagnosis and what that diagnosis means for that particular decision. Also kind of similarly, what cognitive abilities are you most going to focus on here? For some things, maybe it is attention and processing speed, maybe it's memory, maybe it's executive functioning. Psychiatric emotional factors, like pre-existing bipolar disorder or neuropsychiatric symptoms that co-occur with other neurological disorders. Someone's historical values around how they manage their finances and what they want to continue. The family is a wonderful repository of that information, as are previous wills. So usually for one of these assessments, especially a retrospective one, you're looking not just at medical records, you're looking at legal documents, you're looking at estate planning documents, basically everything you can to help make that decision. And then, of course, all the other pieces that you think about, if capacity is undermined, what might we do to get somebody back to that level where they can retain or make decisions, and then ultimately your clinical judgment. Certainly, all the cognitive constructs that we've kind of mentioned already. And this last one is a tough one sometimes in terms of someone's ability to make decisions that the family and maybe you as a clinician or an individual do not agree with versus, boy, this is signs of impairment. That sometimes it's crystal clear, but sometimes it is this person just makes bad decisions financially, and that's kind of the way they've always been, and they understand it, and there's no kind of neurocognitive finding that would say that understanding isn't based on adequate understanding of the consequences, risks, benefits. So that's always another kind of thing to be thinking about. Some tools. There are some great ones for medical decision making. There are also some great ones for financial decision making. Testamentary capacity is a little more scant. There is a Greek tool with some American modifications you can make. But these I don't know that they're critical, but they help both with the framework, and they do help, I think, when it comes time to make a formal determination, especially given that for a lot of individuals, especially older adults who have fallen victim to scams and other fraudulent activity, and there's bad judgment or poor decision making, many of them will have completely normal neurocognitive results, or mostly normal. So there's just certain things you can't capture with traditional neuropsych testing that these can help kind of pull out. Outcomes. So, again, the possibility of guardianship or conservatorship, ideally as limited as possible, and ideally with goal of rescinding that if appropriate. Certainly, proxies or powers of attorney, the idea of representative payee, and then certainly perhaps finding ways to enhance capacity through different modalities. So if somebody has terrible auditory attention and verbal memory, can you present things in a different format and see if that enhances their understanding of the issues and the ability to weigh those in a logical way. I don't think we need to talk about that too much. Skip that. So the things I guess I would ask of all of us as we think about this, the people that we work with, for so many reasons, it's important to identify and document cognitive impairment early. So many reasons that early and accurate diagnosis are important. I think we often assume capacity. Sometimes that's correct. There are certain cases where, I would say in MCI, for most cases of MCI, people probably retain a high level of capacity for most decisions. In late stage dementia, mid stage dementia, capacity is likely globally impaired. So there are those kinds of windows, but boy, there's a lot of territory in between them. And it really depends on the complexity of the decision that needs to be made. I recently learned here in Washington that there is a very different level of evidence for gifting capacity when the giftee is a fiduciary. There is case law that dictates a higher level of capacity there. So, and then also, who are the trusted decision makers? Ideally, this goes back to Dr. Gaster's work around advanced care planning, identifying this as soon as possible, ideally before MCI is present, but as soon as possible, and making sure that you're revisiting that. The other thing that is nice when you're doing a capacity evaluation is to have regular documentation of these are my wishes, these are my wishes, these are my wishes, these are my wishes, because deviations from that become, without kind of an explanation of here's why I'm deviating from that. That helps with that assessment, continuity over time, consistency over time. Some resources there are for capacity evaluations. Boy, I wish there were more people who did it. There are some psychologists and neuropsychologists here in the Northwest that do. There's some psychiatrists that do capacity evaluations. There's a few services here. And then with that, I think I will stop there. And a lot of these things we can talk about in more depth, given that there's connection with the case. But I'll pause with that.
Thank you, Chris, for that great presentation. Kimmy.
Great, thank you so much, Chris. I just wanted to add that I cared for a person with primary progressive aphasia, and she had a lot of yes/no confusion. And I was very, very fortunate to work with some very skilled speech pathologists who were able to take the time to help her document her wishes. So I had, like you're saying, make sure that you know what the person is intending. So the speech pathologists were very, very helpful with that.
Resource.
Nicole.
Hi there. So this is, I recognize, sort of a broad question, but Chris, I have to believe at some time, probably many times, you've had to address one's capacity to get married. I'm bringing this up because we have a pretty complex client situation that we've been dealing with recently where that's been an issue. I'm just curious if there's any specific literature or resources specifically about, capacity to get married, like where that fits in.
Yeah, that's a great question. And the last time I looked, I did not find anything, any specific tools or frameworks. The best advice I have found and have seen so far, I would love to hear it if somebody knows differently, is that you can employ some of these same constructs around medical decision making. Kind of like if you did like a principal components analysis of all the other kind of decision making evaluations you do around ability to kind of state choices, ability to talk about the pros and cons of each. So get married, not get married. Here's what happens if I do, and oh, maybe kids aren't going to be happy, and but if I do, this is hard. So they can do that. They can consistently kind of communicate, and this is why, right? So I know these are my choices. I know these are the outcomes, and here's what I want to do, and here's why I want to do it. I would then, within an evaluation, ideally, you're evaluating that kind of throughout, and then you evaluate that over time. So that's another way to kind of document consistency of choice. So it would be a similar, kind of the different content, but similar process.
Thank you. It's helpful.
And there are so many decisions, right, where there's not a kind of a particular tool, but and then I guess it would also depend on the degree of cognitive impairment and what's causing that cognitive impairment. And right. Well, I'm sure there'll be plenty to discuss as we kind of move through the case.
Barack, did you want to unmute yourself and share, or do you want me to?
Yeah, I don't have that much to say other than,
Okay.
because I mean, obviously, I'm not a lawyer, and I don't not giving legal advice, but I would, if somebody were to ask me about the marriage question, I would think of it as like probably putting it into the same context as other, social contract, legal contracts, so it's not in the realm of like medical sort of capacity, but more in the thinking of it as something that has like lots of legal implications to get married. And do you have the capacity, if you have capacity to sort of enter into other types of contracts, that this would be, a sort of a social related legal type contract to enter into. But again, there are lawyers on the call that I would absolutely defer to on that.
Paige, do you want to comment now, or do you want to wait till later? Either way works, and I see there's a hand, so whatever you.
I would tend to agree with what Brock said, but it's also not my area. It's sort of a civil legal question, but it has come up for me in criminal cases. And when it has come up, it's been in that same context of, does a person have the ability to understand this contract essentially and understand the impact of it? And are they freely choosing it? So I think that's a good framework.
Thank you. Karen?
Yeah, hi, everybody. This is actually a family situation that happened several years ago in my husband's family, when his parents both had early dementia, and there was an older brother who was just getting started managing the finances because they couldn't do those things. Obviously, we started finding out things weren't getting paid and confusion and so forth. So an older brother, very responsible, and who was the executor, financial power of attorney, started appropriately taking over stuff. Well, the younger brother was the one who was around more physically, and to no one's surprise, doing some financially dodgy kinds of things. And then the in-home caregivers actually turned him into adult protective services. So my question about adult protective services is, I was never really clear how they determine capacity, because they came in and both the parents just sang the praises of this younger brother and how great he is, and no, he wasn't exploiting them. And so they just left. And that was sort of the end of the case. And the rest of my husband's family, they're very conflict avoidant. And so this just ended up going on for years. But I just always thought it was interesting, unhelpful, and not knowing what to expect from adult protective services. And if the primary care provider ever gets looped into the fact that APS was called and something happened. Anyway, if you know anything about that, Chris, and can shed some light on that kind of, I don't know how common it is. I'm guessing it's fairly common.
Yeah, it's quite common. And we are organizing an APS didactic for ECHO, just in terms of what they can do, what they can't do. Yeah, and we have an APS component to our case as well, which we'll talk about.
So we will take one more question, and then, because we do have a case that is connected with the didactic, we'll then move on to the case presentation, and I'm sure there will be many questions and comments after that. But Brock?
Yeah, I think I say this every time we talk about this topic, which is, just people, especially primary care doctors, want this to be so kind of like cut and dry and algorithmic. They want just give me the criteria for what the capacity is, and I just want to move. And you just have to kind of give people the frustrating news that it's just really, really hard and frustrating, and every case is really different, and that there is just an awful lot of kind of common sense and do your best, and it's always going to be hard and frustrating.
Thank you. And with that, we will shift to Dr. Frederick Messier, who is going to present the case. And she is a geriatric fellow with Carrie Rubenstein at Swedish, and I know has also been working very closely with Chris Rhoads and with Paige. And then we have a number of other people joining us today who can chime in as well. So thank you, Paige. Excuse me, please, Fred, will you take it away?
Hi, thank you for having me here today. Very excited, and also very excited that we have Paige with us, because Paige's team, through the multidisciplinary team, King County Elder Abuse, is actually the one who brought this case to my attention, and how I actually managed to have this patient establish care with me as his PCP. So I'm wondering, Paige, would you find it more helpful if I present my slides and go through the things, or do you want to give a little bit of background about how this case came to your attention?
Maybe that would make sense, Fred, for me to just explain what the MDT is and how
Perfect.
it came to. Okay, so
Wonderful.
the King County Elder Abuse Multidisciplinary Team is a group that is funded by the Veterans and Human Services Levy in King County. We are now 5 years old. And we started out with it just being the prosecutor's office, which is where I work, and that's who got the original funding, and Adult Protective Services for our region, and Developmental Disabilities Administration, and Aging and Disability Services. And then we ended up developing a relationship with Dr. Rubenstein, who brought in herself and her fellows to participate. And that is when the team started really getting some traction, I think, and really doing some amazing things. And we are now quite robust. We're in our 6th year. And we are also joined by the Geriatric Regional Assessment Team, and then other people from different agencies, depending on what the problem is and what the cases that we're discussing. And so we come together to discuss problematic cases of elder abuse, neglect, or exploitation, or self-neglect, to try to strategize on how we can improve the situation for this person, and also whether criminal charges should be stemming from the case as well. And a lot of it is about sort of goading some more reluctant agencies into action, and trying to engage different players who really should be involved in a case of that complexity. So that's sort of the background. The case we're going to talk about came to me through a Seattle police detective who reached out to someone else in my office and was referred to me, who was very distressed about this older man who she was watching be scammed really quite savagely by a number of different scammers. And she was doing everything she could to try to help him, and he remained convinced that these scams were investments and they would pay off, and he was very, very resistant to any kind of intervention. So I brought that case to our MDT, and then Fred, I'll let you take it from here.
Yeah, so when we first heard about this patient, came to our attention that the patient had a cardiologist, right? And that was pretty much the only active other professional that was part of his medical team. And so we were able, when I say we, I can't take all the credit for this, because my wonderful program director, who's here and listening to us today, was instrumental in this, in having the patient trust me. But we reached out to the patient's cardiologist, who had been a long time, provider in his life and whom he trusted very much, to let the cardiologist know about the situation and ask, if he had, and of course he had not been aware of anything besides in regards to the patient's capacity or all the scams that were going on. So the cardiologist recommended our clinic as a good place to get primary care. And so he actually came to visit us in clinic one morning, and I remember us being very excited that he was actually there and establishing care. We were able at that time to do a functional assessment and a MOCA, and I have some slides to share for the purpose of making this a little bit more okay. And I am assuming that everybody can see my slides. Perfect. So when this person first came in, my first thoughts were, this is a vulnerable older adult who has not had consistent primary care for a very long time, and he is in a situation that puts him at risk for many things. And so taking a step back and looking at it from a 5M perspective, right? What matters most to him, what his meds are, what his mentation is like, which, depression, dementia, and assessing for mobility and any other things that we might be able to help with. And so just for a little bit of history, this person lives in a house alone. He's widowed, and unfortunately his wife died about 8 years ago from cancer. And this correlates with when he started, unfortunately, being enrolled in a lot of these scams, which he sees as investment opportunities. And just to kind of give you an idea, one of the scams is like he thinks that he's winning the lottery, right? And every time that I see him, he's convinced that there's this $89 million prize that he has won and that he needs to pay taxes on to be able to win the prize. And so he's explaining to me that, you know, he's been mailing $50,000 checks to this person because he needs to pay the taxes on his prize. And he's even mentioned that once he wasn't home, and because of that, they were there and they took pictures of his home and tried to deliver the prize, but they couldn't because he wasn't there. So now he's very anxious about not being available to them. And they call him about like 50 times per hour when I'm with him. So I can imagine that that's different when I'm not there. And he's very afraid of leaving his house too. So that morning when he first came to see me, he was very apologetic and answering the phone and telling them, "Oh, I'm sorry, I'm at my doctor's office. I can't, you know, be there." Very worried that he was missing out on his prize being delivered while he wasn't there. And this is obviously, you know, impairing his function and taking a big part of his time. Unfortunately, they don't have any children, and they have very little close friends or family of choice. His sister lives in another state, and they have very little contact, and he's very resistant to us involving them in this. He has, of course, very limited insight into what's going on. He is a very educated person. He has, you know, master's and undergraduate degrees, and he was an engineer, and then had a very big real estate empire and was at one point an owner and operator of almost 200 units. And his understanding and his level of function right now are definitely different than something that I would expect from someone who's been this highly functional previously in his life. In terms of medical history, and Chris can speak to this a little bit more, because after I initially saw him, we managed to in a coordinated effort to get some answers and possibly some help and support for this person, have him scheduled to undergo neurocognitive testing. But he was diagnosed with major neurocognitive disorder in June of this year. And he had previously, you know, suffered from a stroke and had some vascular disease, and you'll notice here that he had warfarin-induced coagulopathy, and he is at this time still on warfarin. If we take a look at his med list, unfortunately, he is on Coumadin, which is one of the medications that I'm very worried that he's on, just because of how much this needs to be monitored. And we've been trying to get him to switch to Eliquis, but he's worried about the copay, which is very unfortunate. So we're actively working towards insurance plans and trying to make this a safer med list for him. And fortunately enough, he's not on any benzos or, you know, like high risk opioids, but still very concerning in terms of medication compliance as well. And so what I've been really fortunate to do is a MOCA with him. He scored 25 out of 30, and which is abnormal, especially considering his high level of education and prior level of functioning. And Chris can speak a little bit more to the more elaborate test that he was able to do with the patient. But I want to bring your attention as well to some of the things that I was able to do, because I, as a fellow, have the luxury of going on home visits for some patients. And this is a picture of the patient's porch. There has been, on top of the scam that I already mentioned, a lot of concern for construction scams. So there's a lot of people who came in to do construction, and this has been going on for too long, if I may, but at least a year. And there's actually concern that they broke things inside of his house and caused water damage, and he, you know, is still living with the humidity and the, you know, moist, and possibly some concerns for his house being contaminated with some of that water that leaked, and that was never really repaired. They did charge him though for the repairs. So this is a picture of his front porch, and this is just to say how wonderful my geriatric program is. Being able to do home visits for patients like these is game changing. I am able to see how they move in their space and really kind of assess if they have food in the fridge, and we'll see a little bit later, how they reconcile their meds, right? What does their mediset look like, and actually see all that information that we're really not privy to when we're in the hospital or in the clinic. So this is outside, and there's actually a huge hole in that porch, which has not been repaired. The picture on the left is where the patient sleeps. He sleeps in the basement because all the other rooms in this mansion are not either in construction, or there's some like semi-hoarding, as you can see in some of the pictures. So he lives in the basement exclusively and showers on the 3rd floor because there's one working shower. But I'm doubtful that he actually uses it as often as he says he does. And some more pictures here. So I, took, and this is, and we can notice, all these unopened letters and bills on the counter. And this has been an ongoing concern for us as well. And luckily enough, we've been able to have a daily money manager gain his, when I say gain, this is always a little tricky, but manage to have the patient accept help from a daily money manager. And so they're doing a lot of things to try to simplify the patient's finances, because there's a lot of concern for things that were not being paid, and a lot of debts that he has for lack of being able to pay all these things. And then in terms of medication, I also took a look, if you see here on the right, at the pill bottles, and seeing how he organizes his pills. And was surprisingly able to recall most of what the indications were for his drugs. And then here are some more pictures of some of the rooms in the house. And when the patient, had me visit the house, he mentioned since his wife died, he's been kind of postponing cleaning things up, and apologetically so. There's some pictures of when I do home assessments. I look at the fridge, I look at the expiration dates, and he, has fresh food, and always check a weight as well to make sure that weight is stable and that he's getting the proper nutrients. And then we're monitoring his blood pressure, and this is his homework here that you can see. Yeah, so hopefully this gives you a little bit better of an idea about who this person is, and I'm here for any questions that you might have.
Thank you, Fred. Yeah, and it really does highlight the value of that home visit as well, to just give you more of what his lived experience is, that you wouldn't have access to
Absolutely.
otherwise. And I'll just, Paige added, I can read it, or you can just elaborate if you'd like, that, it's not that he's unable to, do these home repairs or make these copays, even though he's lost quite a lot of money.
Yes, that is an excellent point. So I was actually talking with a detective not too long ago, and with his money manager, and this person had many millions of dollars, and it's estimated that he's lost about $3 to $4 million to all these scams, but he still has a few millions left, and the house itself is worth a couple of $1 million. So his concern for the copay of Eliquis is, in my professional opinion, because of the risks of being on warfarin, not exactly justified, but that just, speaks to his inability to think about these things. I had a visit with him last week. He was really upset, and Paige can tell us some more about these processes, but he's, their APS, and there's a guardianship procedure that's in progress. And he was really upset about the city and how they were trying to get a guardian and trying to take control of things. And he was like, everybody's against me, the city and my doctor. And then he kept going, right? And without realizing that I was the doctor who, made that assessment. And so, yeah, just kind of ongoing. And then we talked about Thanksgiving. He was very happy to talk to me, and very, very engaging. So very interesting dynamic for sure.
Carol.
Yeah, question. Great case, Frederic. Thank you for sharing. One of the questions, it seems like one of the challenges is that his sort of his particular manifestation of neurocognitive disorder is a little bit unusual. Like he's very fluent, it sounds like. He has lots of language. He has some cognitive domains that are quite maintained and others that are not. And in my experience, that makes it really, really hard. That makes these sorts of determinations harder, right? He can appear sort of like if you hadn't seen the pictures of the house, you would not have had a sense of how poorly he was.
Absolutely.
So
As
how
a
did you use
wife,
that? Yes. So how did you use that? I mean, so how did you decide like, yes, this is a person who has lost capacity versus this is a person who's making bad decisions? What
that
happened?
is a great question. His ongoing absolute belief that these, which is obviously, you know, a scam, that this is something that is happened, like that might, you know, get him to actually have this prize, or his inability to function because of this concern, this ongoing concern that he has for you know, continuing to invest, and just speaking about the scammers, of course, but also his decrease in function, and really the change. I mean, obviously cognitive impairment, right? We have abnormal cognitive tests, and the change from his previous function is what led us to believe that he has, you know, a major neurocognitive disorder, that he has dementia. This is not what his baseline used to be, right? He used to be a very highly functional individual, and now I see this inability to care for his finances and getting into trouble and giving all this money away and being in debt with the city for, you know, things like paying his mortgage and the house and everything as evidence that something is wrong. Yeah.
And Fred, can I jump in there too? So we also had APS had done their very, you know, I think some capacity screening on him. I'm not sure, they may have administered a MOCA, and because he scored fairly high, and because of the reasons you articulated, Carol, they were very reluctant to take action. And so then we got him evaluated by Karin Tyfor, who many of you know, I'm sure, who did a really nice eval, but also wasn't getting the basis for a guardianship from the testing she was doing. And so that was when we brought in Dr. Rhoads, and it was based on his evaluation, I think, in conjunction with Fred and Fred's work with him, that we were able to get the information needed by the Attorney General to file the guardianship petition. But it was a real lesson for me in how sometimes getting someone who's a very good capacity evaluator isn't enough. You've really got to get this neuropsych perspective to get the information that will convince a court that a guardianship is appropriate.
Brock?
And so I see Barack
Yeah, or Chris, yeah, can we call him Barack, and then we
Yeah.
can hear in more depth the neuropsychological assessment and capacity determination that you did. Thank you.
Yeah, so sorry if I missed this, but I guess one of my first questions would be, you know, somebody of his means who has such a long history of doing complex business dealings with real estate and stuff, I would imagine that he has had, and you know, he's hired lawyers in the past, or has had relationships with lawyers, professional relationships with the lawyers that maybe he would trust. And I'm sorry if you said that and I missed it.
I think he has worked with lawyers quite a bit. I don't think he's in contact with any of them now, Brock. And I think what we got him also engaged with was this money manager that Fred mentioned. And he, even though he's also part of sort of the system, he ended up trusting him quite well, and is continuing to work with him. And that money manager recommended an attorney for him to use in the guardianship process, but he didn't seem to have anyone else that he was. He mentioned them, but he never was able to reach anybody, and really wasn't in contact with anybody anymore.
Yeah, I mean, just like trying to think of people who have been in his world who he might have some trust with.
Yeah.
And, like often somebody like this will have a lawyer who they've worked with for years and years and would trust that you might sort of turn to get some help.
And I've had other cases where that was the case, and those lawyers ended up watching their friend be exploited, and they ended up becoming really crucial players in the criminal case and the civil case that followed.
Yeah, Brock, you're asking one of the questions that is part of the capacity evaluation. So when I saw him, the question was twofold. One was, the nature of his cognitive impairments and maybe etiology driving that, and then does he have capacity to make financial decisions around? Is this just he wants to contribute to this lottery? So, and part of the process was obtaining consent for both of those. So he came alone, and I had a chance to review the evaluation that was done in May. And at that point, he had a slums of 27. He had a Rhoads of 24. The frontal assessment battery was pretty normal. Trails A was fine. He couldn't do Trails B. Didn't say why. So the determination at that time was, well, he doesn't really need guardianship, but he certainly seems like he needs some protective arrangement to help with his financial losses. So when we sat down, I said, the purpose of the evaluation is twofold. One is to try to get a sense of any changes in cognition and what may be causing those, and then also to get a sense of your financial decision making, given that there have been concerns raised by the Seattle Police, Protective Services, your providers. And he was able to consent to that. I did share with him that the report will not just go back to his referring provider, but also to probably the people in the multidisciplinary team. His history was interesting in that he was kind of evasive about how much money he had lost, and it didn't seem like he was misremembering that. He was kind of protective of kind of what was going on. But otherwise a pretty good historian, and he mentioned that he's worked with CPA for a while with both his taxes and more complex financial matters, but since kind of getting out of the real estate world, hadn't been in touch with any real estate attorneys. But otherwise, acknowledged that his driving habits had changed. He didn't really drive to downtown Seattle anymore. Kind of hard to keep track of those environments. Otherwise, pretty good historian. The findings were notable for, and I can share on the screen here. I had some slides that disappeared, but let me share this quickly. So he is a brighter than average individual, which fits with his educational occupational history. He's got a little surface dyslexia on one of the irregular word reading tests, which raised a little concern. But to your point, attention, concentration, processing speed, pretty good. He was able to do Trails B for me with a couple of errors, but did it within 97 seconds. His Stroop color naming was fine, inhibition was fine, word reading was a little low. I think that's just kind of a spurious finding. I don't think there's much to that necessarily, because it doesn't fit with anything else per se. His modified Wisconsin was okay. Tower test was quite impaired. That's a test of planning, problem solving. He had trouble there. He had trouble kind of inhibiting, things that he shouldn't be doing on that. He had a lower than expected score on a measure of confrontational naming. His fluency was impaired bilaterally, or on both kind of conditions. And then what was super interesting was on a task of kind of like writing a check to pay a bill. He had an impaired score there, so he couldn't kind of keep track of the prior amounts. He made some mistakes filling out the check, so that's concerning. His visuospatial skills were largely okay. His complex figure copy was impaired because of his organization. And then on memory, he actually did pretty well, better than one would expect. Did great for visual information. He had trouble kind of capturing and acquiring information, but what gets in largely stays in. These are some simplified tasks, but some slightly lower than expected scores based on his premorbid abilities and normative data. Not depressed, not anxious. The other parts of the capacity evaluation, though, kind of worth talking about. So he's got preserved knowledge for simple financial information, but had significant difficulty as the tasks increased. He was pretty tangential and hard to kind of keep on track of some of this. He really couldn't fully identify his current assets, where his banks were. And I had information about this from, Seattle PD and a few other things. So I had a decent sense of where things were. He did have a pretty consistently documented preference for his investments. Was able to talk about his historical values of who he liked to donate to, and that did not include scammers. He really couldn't identify any trusted individual that he would want to help with his financial decisions. But then, he kind of talked about his CPA or maybe his sister, but then he talked about his neighbor. I really didn't know my neighbor that well, but he's closer than either my CPA or my sister. When I asked him who he wouldn't want to have involved in anyone's financial decisions, he couldn't identify anyone. And I kind of cued him and said, nobody at all. And, is there anybody that you would worry about taking advantage of your finances? And he still didn't really respond. And then finally was able to identify, well, I guess maybe I wouldn't want the scammers involved in my finances. So his overall score on that was kind of below what would be acceptable. And then some increased vulnerability in terms of his isolation. And also kind of getting into his perceptions of what are the likelihoods of winning this lottery. And he had this really convoluted story about how his subsequent investments in this lottery actually paid off his initial investment in the lottery, so therefore he really wasn't scammed out of that much money. And it's coupled with the executive dysfunction. So the upshot of it was, I thought he met criteria for major neurocognitive disorder, likely vascular etiology, although some of the language changes and some of the memory pieces might hint at a comorbid Alzheimer's component. Recommended imaging, which I don't think he's ever gotten, to help rule that out or rule that in. And then a few other recommendations. And I thought, he had capacity to manage his day-to-day affairs financially, but lacked capacity for more complex financial matters and would benefit from a limited conservatorship. That's kind of where I left it. And my understanding is that ultimately was granted, but boy, it took a while.
I think it's still ongoing.
Still ongoing.
Yeah, but the state is following your recommendations and pursuing a limited guardianship. They found a really good guardian who will, and the beauty of it is once they're actually appointed, they will contact these scammers and basically say we're taking over his assets, and then the scammers will depart immediately. So it'll really be very effective at preventing him from being scammed in the future. But he is continuing to be scammed as we speak until this guardianship or the conservatorship happens.
Paige, is there anything else that you would add from the MDT side or the prosecuting attorney side?
Just the importance of having you, Chris, and Fred and Carrie, and this capacity, these really quality capacity assessments are essential, obviously, to protecting people and to allowing people to live their lives the way they want them to. But also for us, as far as in criminal cases, this is not one of them because these scammers are international, we think, but in a lot of cases, we're dealing with family members who are doing this exploiting, or friends or some acquaintance of the person who is someone who is locatable and identifiable. And the only way we can really prevent things from continuing and protect the person is by determining the older adult's capacity. And that is essential to APS taking action, to a guardianship or conservatorship being put in place, and to a criminal prosecution of the offender. So it's really at the crux of all of these cases. So I'm just so grateful for this collaboration with you all.
Nicole, you had a
Oh,
question?
yes, thank you. This is just curiosity, I guess, but I'm thinking of some folks, somewhat similar circumstances, maybe not quite at this level, but it seems like, in a lot of these situations, there's this problem that becomes huge and gets attention. And once you're able to get in a little bit and put all the pieces together, you find evidence that a lot of other things have been going on for years prior. I'm just curious with this gentleman, was there any glimpse into like what's been happening for him since his wife died the last 5 years? Like, were there other examples that came to light of him not functioning well in his life? I don't know if there's any history on that.
It's great.
Just
What was he
curious.
like? What has he been like? Is this a change? Who might, as a parallel historian, offer perspective? Is it?
I think that was the problem, is we really didn't have people. I don't know if he did a look back with him, or if they did in their, APS investigation look back more than recent. Because we did get numbers, about how, and I don't know if it's been said, but $3 million. So and that he probably still had about $7 or $8 million. That was sort of so somebody looked back, Nicole, and saw that this had been happening. And I don't know for exactly how long, but the problem was that he was otherwise sort of functioning okay.
Yeah, it sounds like he was seeing the cardiologist at least.
Yeah. He's
managing
got
his
that warfarin,
medications.
right, which makes people like actually have to show up. Like very few other treatments that we do on a regular basis, and he was doing that. And so it's a really good question, is like the duration of this, the severity of this.
I think he'd been scammed for years. I think he had some of these relationships with these scammers are now long term. So they're people who've been in his life for a long time. So it definitely had been going on for a long time. But that's all we know.
Thank you.
And Brock, you had a question?
Yeah, I mean, for me, this brings up the, like, thank goodness for Chris Rhoads, and how wouldn't it be great if there were 1,000 times as many Chris Rhoads as there are in the world, and just like the practical problem of how many people there are who need this kind of evaluation, who can't get it because it's so expensive and time consuming. And so I'm sort of curious, in a situation like this, like I imagine that, this took a lot of your time, Chris, and your time is really like valuable. Like, so was this paid by his medical insurance, by the city? Did he pay for it out of pocket? Like, how does evaluation like this happen?
It's insurance. I saw him at Harborview in the neuropsych testing service, and had Medicare. Getting him in the door, creating space for that is the challenge, right? I mean, it's not
If I can add to that, it was kind of hard to convince him to go because he was really worried about the $35 copay to see Chris.
But his insurance did cover it.
Yes.
This was covered by Medicare. Medicare covered this. Yep.
And so interesting about that, though, I mean, if it's a capacity evaluation and not kind of a medically necessary diagnostic and capacity, I'm not sure. I'm sure there's ways to do that, but no, it's more of it's time consuming because it's nuanced, right? I mean, I maybe there are providers out there that would be comfortable saying, oh, he's got a MoCA 25, this behavior doesn't sound right, he lacks capacity. I wouldn't do that. You're opening yourself up to some significant risk doing that. So, but that point of, there should be more of this out there. Absolutely. A lot of people do need it.
Yep. As Carrie adds, she had to run, but she's, noting the inequity here, and that they were only able to access the service because of the work with Paige and in the community. And so many are left vulnerable to these very skilled, incredibly persistent predators. And most are really isolated, as you pointed out. So great discussion of a very challenging situation. And thank you, Paige and Fred and Chris. And again, please bring your cases forward, and reminder about the CME and upcoming didactics in the new year, and the Innovation Summit. We hope you can join. And this is our next session on Alzheimer's disease, the ADRC, the Alzheimer's disease research clinical center clinical trials with Teresa, I don't know how to, Kane, maybe? And the 1-minute survey. Thank you all for coming, and have a happy holidays to everyone.
Thank you.